May we call on Dr. Ricardo Francisco, Section Head of Veterans Memorial Medical Center.
Good afternoon. In behalf of the Section of Nephrology of the Veterans Memorial Medical Center, I would like to welcome everyone to the first Nephrology Forum since 2001. As you know, during our time when we were still fellow, we have the regular Nephro Forum, but unfortunately, along the way, nakalimutan ata. So, during our time, may natutunan naman kami sa activity to. So, I'm glad that the very energetic head of the Committee on CME revived the Nephrology Forum, and I'm also glad that we will be the first to host this scientific activity. So, thank you sa CME na na-revive nyo to, and we hope that we will learn from this scientific activity. Thank you.
For the case presentation, the clinical history and PE will be discussed by Dr. Charmaine Joy Miki Almuela, our first-year fellow, and followed by renal pathologist of the National Kidney Transplant Institute, Dr. Sonia Chicano, to discuss the histopathology regarding the normal and the histopathology of the case, and the clinical course and treatment discussion will be talked about by Dr. Ramon Mor, one of our active consultants here in Veterans Memorial Medical Center. So may we call on Dr. Mike for the case presentation.
So good afternoon. For our topic, so it's entitled The Unlikely Pair. So lupus in male. For our case, we have MD, a 27-year-old male, single, an engineer, a Roman Catholic living in Balayan, Batangas, who was admitted for the first time at Veterans Memorial Medical Center with a chief complaint of history started about 2 months prior to admission, when patient initially presented with sore throat associated with joint pains. There was no fever, hematuria, edema. Hello, ayan, okay na. So, the assessment then was upper respiratory tract infection. The patient was given erythromycin and celecoxib, which provided relief to the joint pains. However, the sore throat of the patient persisted, now with associated erythematous rashes on the face. Hence, another consult was done at Paranaque doctor. The patient was again given clindamycin, but this time was requested for complete blood count, urinalysis, ASO, creatinine, and electrolytes. So, 1 week prior to admission, the patient had persistence of the skin rash. A follow-up was done, now with the following laboratory results, which revealed on the CBC there was anemia. The chemistry showed azotemia of 170.3 millimole per liter. The ASO was negative. Urinalysis showed proteinuria of +4, microscopic hematuria of 30 to 40 per high power field with 30% dysmorphic RBC, and also pyuria. So the patient was then referred to our institution for further evaluation and management. When we've seen the patient, we eventually advised the patient for admission and kidney biopsy. Hence, the patient was admitted. So for the past medical history, it was unremarkable. For the family history, his father is diabetic. And for the personal and social history, the patient is an electrical engineer who primarily works in the construction sites. He's non-smoker, an occasional alcoholic beverage drinker, has only a monogamous relationship and denies risky sexual behavior, no illicit drug use. So for the reviews of systems, what's only pertinent is that there's weight loss of around 10% in the last 2 months. For the physical examination, the patient is hypertensive with blood pressure of 150/90. For the physical examination, there's a note of hyperpigmented patches located in the malar area. Malar area and frontal area that is darker in shade in contrast to the neck and more pronounced in bony prominences. There's also a note of hyperpigmented patches all over the anterior and posterior torso with areas of erythema, which is non-purulent, some is coalescing and discoid in shape, non-dermatomal in distribution. So, the patient, for the head and neck, the patient has pale palpebral conjunctivae, non-hyperemic pharyngeal wall, otherwise unremarkable. So for the thorax, there is crackles noted on the left base. For the cardiovascular, it was unremarkable. For the abdomen and extremities, it's also unremarkable. For the neurologic examination, unremarkable. Yun. So for the salient features, we have a 27-year-old male who has history of non-deforming arthritis, an electrical engineer, so having an exposure to the sunlight, is hypertensive, has malar rush, has pale palpebral conjunctivae, which could, because of the anemia of the patient, has proteinuria with dysmorphic RBC, negative ASO, patient is azotemic, and patient is also has anemia. So from the 1997 American Rheumatism Association, so from this criteria, we know that if you fulfill at least 4 criteria, four of any of this, it gives you about 96% sensitivity and specificity in diagnosing systemic lupus erythematosus. So for our patient, he had malar rush, he has non-deforming arthritis, hematologic disorder, which is anemia, and yung proteinuria and yung dysmorphic RBC. So, when the patient was admitted, we requested for these laboratory examinations. So the C3 was low, about 30 milligrams per DL, NA was positive, and for the CBC, there was leukopenia and anemia. Also, there's persistence of your azotemia, hypoalbuminemia, and dyslipidemia. So for the urinalysis, there's persistence of your proteinuria. ABG is within normal. For the chest X-ray, there's note of pleural effusion on the left schizophrenic angle. So by this time, he has all of this, he fulfilled all of these criteria, which makes a strong diagnosis, consideration of your systemic lupus erythematosus. So for the guided management of the patient, we then requested for kidney biopsy. So for, to present for the histopathology of our patient and a brief review of the normal histopath of the kidney, so we now call on Dr. Rachikan.
So before we go to our case, we review the normal glomerulus. So again, most of you have heard this many times before. So we have Bowman's capsule lined by a single layer of parietal epithelial cells. We have the glomerular tuft. We have the capillary loops lined inside by 1 to 2 endothelial cells per capillary loop. We have the mesangial cells within the mesangial area. We normally see 1 to 3 mesangial cells per area. So for us to have hypercellularity, it has to be more than 3, and they have to be crowded instead of being in line. Now, these are the podocytes or the visceral epithelial cells seen outside the capillary loops. So the capillary loops are thin and delicate, and they are open. So now we go to our case. For light microscopy, we have 11 glomeruli. So as you can see, this does not look normal. What do we have here? This is the Bowman's capsule. We have the capillary loops. In some capillary loops, we don't see the lumen anymore. Why? Because there is proliferation of your endothelial cells, as well as the presence of inflammatory cells composed of your neutrophils and mononuclear cells. We also see increase in mesangial cells. what is also striking here is that the capillary loops are not anymore thin. So normally, we compare that with the normal tubular basement membrane, which is thin. So here we see thickening of the capillary loops, and the thickening is eosinophilic, and it is towards the lumen. So these are what we call the wire loop lesions. Next, this is still PAS stain, and we see the glomerular tuft, we see the Bowman's capsule. Again, we see cells filling up the capillary lumen. So this involves more than 50% of the glomerular tuft, so it is something that is global. And this lesion involves all glomeruli, so again, it is diffuse. So aside from the wire loops, which we saw earlier, the endothelial cell proliferation, mesangial cell proliferation, we also see a collection of cells outside the glomerular tuft, but within the Bowman space. So here we see a cellular crescent. So remember, this patient has elevated serum creatinine. Another glomerular loops, again, Bowman's capsule, we see the cellular crescent outside the glomerular tuft. This is our glomerulus. We also see hyaline thrombi here. So these are just large deposits that protrude into the lumen. Now this is silver stain. So here we can see better the wire loop lesions. So these are the wire loop lesions. The black line represents our glomerular basement membrane. And this pink deposit, these are now our wire loop lesions. And we see hyaline thrombi within the capillary loops. So this slide does not show any cellular crescent. Here we see the cellular crescent. Okay, so again, the hyaline thrombus. We have the wire loop lesions. So in some areas, the glomerular basement membrane appears to be incomplete. So we also see GBM rupture, or rupture of the glomerular basement membrane. Here is our cellular crescent. So again, our crescent, we see the deposits, hyaline thrombi, and the wire loop lesions. So this is H&E stain, again illustrating the wire loop lesions and the hyaline thrombi. And this is our endocapillary proliferation, so we don't see the lumen anymore. So aside from the glomerular changes, we also see tubular changes. Tubules are dilated with flattened epithelium and loss of brush borders. This is trichrome stain, and we see edema. So there is widening of the interstitium, and the interstitium is loose. So this patient has very little interstitial fibrosis. It's more of edema than fibrosis, which is a good thing since this is reversible. There's no artery in the sample, but the arterioles also within the sample are unremarkable. Here we see interstitial infiltrates composed of mononuclear cells. So now we go to fluorescence. As you can see, we have a full house immunofluorescence. 3 of a kind, 3 immunoglobulins, and 2 complements, or 2 of a kind. And the deposits are seen in the GBM as well as in the mesangium. In some areas, we also see the hyaline thrombi. So for C3 and C1q, we also see some extraglomerular staining, such as in the TBM, tubular basement membrane, in the blood vessels, as well as in the interstitium. So this is not unusual for lupus nephritis. So now we go to EM before we discuss our case. So this is our normal glomerulus. Again, Bowman's capsule, parietal epithelial cell, capillary loop, endothelial cell, 1 to 2 per area. These are the visceral epithelial cells or podocytes. Mesangial area. So we have 1 to 3 mesangial cells per area. And if we look closer, this is our glomerular basement membrane. These are our foot processes. This is the lumen. So again, this is part of the podocyte. This is part of the endothelial cell, so our endothelial cell fenestration. Our glomerular basement membrane, subepithelial, intramembranous, subendothelial regions. And we have the foot processes, which are separate, and we see slit pores in between. Now we go to our case. So as you can see again, it does not appear normal. Do we see the foot processes? No more. We see effacement of foot processes, which is widespread in our case. And the area right underneath the visceral epithelial cell is the subepithelial region, and we see some subepithelial deposits. We also see intramembranous electron-dense deposits. But what we see here, which is the most striking, is the presence of this large confluent subendothelial deposit, which we see on light microscopy as wire loop lesions. So again, Bowman's capsule, we also see some deposits in the Bowman's capsule, a capillary loop with very large deposit, subendothelial deposit. So again, another wire loop lesion. So remember, we saw the wire loop lesions on light microscopy. So again, these are the subendothelial deposits. This is our endothelial cell. So here, we see many subepithelial deposits. So that is why our classification is a combination of class 5 and class 4. Mesangial area, we see mesangial deposits, paramesangial deposits, capillary loop, again subendothelial, and some subepithelial deposits. So we look at the details of the deposits. We don't see any substructure. Sometimes we see the fingerprint pattern or the curvilinear deposits. Here we don't see that. And if we look at the endothelial cells within the cytoplasm, we see these structures. So these are the tubular reticular inclusions, which is a sign of activity in lupus nephritis, but it is not specific. So this is from the book. This is your tubular reticular inclusion, and this is from our case. So we see two tubular reticular inclusions here. So if we do the activity and chronicity indices, here we see endocapillary proliferation. In all glomeruli, it is global, so we give it a score of 3. Crescent, 1. Karyorrhexis, wire loops, hyaline thrombi, rupture of GBM with a total score of 13. And for the chronicity index, we have segmental sclerosis seen only on immunofluorescence, so we give it a score of 1. So we have chronicity index of 1. So our diagnosis is lupus nephritis 5 and 4, so membranous and diffuse, with activity index of 13, chronicity index of 1, 19% cellular crescents, and 8% segmental glomerulosclerosis.
Any questions for Dr. Rajkan or clarifications before we proceed with the clinical course and management? So if there's none, may we call on Dr. Ramon Mora.
I'll be talking about is I'll just try to stay a little, hopefully, a little time with why males suffer a severe lesion compared to female. And then I'll try to go on what's available outside the standard of care of IV cyclophosphamide. Okay, so as we all know, SLE typically affects the females at far greater rates than males. However, male patients often have more severe disease than females. As a minority, males with SLE have been frequently subjected to treatments studied mostly in females. No? So napapansin ninyo, yung gamutan, magkasama yung babae at lalaki. So kung sinama mo yung lalaki sa pangkaraniwang gamutan, halimbawa IV cyclophosphamide, maaring magdulot ito ng pangit na resulta, considering na alam mong pangit from the beginning pag lalaki ang pasyente mo, kasi ang presentation niya, severe lupus nephritis. Okay? So, we'll try to go a little further on what is in a male, what is in a female, that may determine the degree of inflammation. So, this is a table that shows the different studies whereby it has been shown the non-renal manifestation of SLE, which is more prominent in males. I won't be dealing so much on all of this, but I will be rather talking more on the Lumina study. These are the studies from US, these are from the Latin American countries as well as Molina, and this is a Greek paper. So Lumina is lupus in minorities, nature versus nurture, Lumina. This is a multi-ethnic US cohort consisting of Hispanics, African American, and Caucasian patients. To further understand the impact of gender on manifestations and outcome of SLE, researchers in the Lumina group compared disease activity in males versus females. So there was a tendency towards more frequent renal involvement, that is 63.5% in male compared to 52% in female. And more often, they have positive lupus anticoagulant in males with about 21.4% versus 9.1% in females. One thing here is that damage was shown to accrue faster in males. Male sex was a strong predictor of damage at baseline and positively associated with damage over the course of disease as measured by the last visit from the time of their baseline visit. So you would notice here, no, ang emphasis dito, mas maraming organ affection ang na-demonstrate nila sa Lumina study, and from the moment of presentation, mas mabilis ang course ng disease. And they have observed further that in this paper of Lumina, Gladel, Molina, and Stephanie Du, they have shown that there are indeed more male patients being afflicted with lupus, and apparently, if these males are afflicted, it is more severe in clinical presentation. So, renal disease in SLE is a source of major morbidity and mortality. It develops in approximately 60% of patients with SLE, with a reported 5 to 22% of these patients progressing to ESRD, requiring dialysis or transplant. There are multiple factors, and you would note here that male sex is a risk factor for increased progression to ESRD. So males, as cited, they have higher prevalence, poorer renal outcome, they have poorer overall survival rate, they have higher prevalence of class 4, DPGN, and active glomerular disease. So let us now try to see what is in the hormone. So sex hormones are probably partly responsible for the higher occurrence of autoimmune disorders given the female predominance in autoimmune. Marami nga ang babae, pero mas matindi kung magkakaroon man ang lalaki. The hormone regulation and effects on cytokine production along with chromosomal factors contribute to the high female predominance in these diseases. The increasing levels of certain cytokines and the estrogen receptor may be important in the disease development. So we have estrogen receptors, which are nuclear hormone. They are nuclear hormone, and they have prominent effects on the immune function. These estrogen receptors play an important factor in the immune function in the both innate and adaptive immune responses. Now, genetic deficiency of, if there is a diminished ERA or ER alpha in murine models of lupus results in significantly decreased disease presentation and prolonged survival. So sinasabi natin dito na estrogen helps in the presentation. But if we lack the receptor, particularly the alpha, there is less clinical presentation of lupus. So the ERA, the estrogen receptor alpha, is expressed in most immune cells, both at baseline and at increased levels after estrogen is given. In particular, on antigen-presenting cells. So it can be seen in thymocyte, in bone marrow, non-hematopoietic cells, the T cells, B cells, and the dendritic cells. So in estrogen, the active hormone estradiol can modulate lymphocyte cytokine production. It can modulate cytokine receptor expression and activation of effector. And that's why they have a role in stimulating thymocyte immune responses, thereby producing lots of these immunomodulatory cytokines, favoring autoantibody production. Now, how about going into the mail? Okay, now we tried to write a letter to the author, Hughes. No, apparently he's the only author who did not answer our letter. But anyway, we have a short note about this, and they have identified 18 independent autosomal genetic loci in SLE. And they have found out that male has a twice risk of having these 18 independent autosomal genetic loci. So, mas marami na naoobserbahan sa mga lalaking may lupus na meron silang susceptible loci for SLE. So probably that may be one reason why genetics in male, they have a severe presentation of lupus nephritis. So the other is that it has been shown that in female, the 17-beta estradiol, the main female hormone, is capable of inhibiting inflammatory and pro-apoptotic processes and protecting the renal tissue. In contrast, male testosterone and dehydroepiandrosterone have the opposite effect. So, ang sinasabi natin dito, yung 17-beta estradiol seems to be protecting the kidney. That's why they don't present a severe lupus nephritis. Whereas testosterone and this hormone favors inflammation in the kidney, causing severe lupus nephritis. So, female gender is therefore considered a protective factor in many kidney diseases, not only lupus, but it can also be observed in primary GN, autosomal dominant polycystic kidney disease, and even hypertensive nephropathy. Now, the androgens may contribute to continuous loss of kidney cells through stimulation of programmed cell death, which is activated in several chronic kidney diseases. Studies in vitro indicate that androgen prime the FAS and the FAS-L-dependent apoptotic pathway in the kidney tubule cells. That's why this mechanism of cell death is observed in androgen compared to that of the estrogen. So there seems to be a line of programmed cell death. The apoptosis is more observed among male who has androgens. So we have gone through the possible reasons why a male is badly afflicted with lupus nephritis. So let us now try to go to the standard of care for proliferative lupus. So still for class 4, nariyan pa rin, steroids plus cyclophosphamide. And then, as we all know, we have the NIH and the Eurolupus to support the use of the IV cyclophosphamide. And then after going through the IV cyclophosphamide, we may maintain them on azathioprine and MMF. And then for those who are intolerant to MMF and azathioprine, we can go to CNI along with the steroid, And how about class 5? If it is non-nephrotic, which is bihira, because kalimitan ng membranous is nephrotic, we can just go on probably ARBs, maybe use an immunosuppression for those with extrarenal manifestation. But for those with nephrotic, we can use corticosteroid, same thing like DPGN, we can use cyclophosphamide. Now what do we do if it is a mix, just like in our case? We use, as dictated, we can use what we are doing, what we are giving in proliferative GN. So we can give IV cyclophosphamide, and further in Brenner, it is suggested that you also give a CNI. Okay, so what is now the future? So this is a mycophenolate mofetil. I know you have used so much about mycophenolate. So although the standard of care for induction of lupus is cyclophosphamide, recent trials suggest that MMF may be as more effective and less toxic. Okay? May be as more effective and less toxic. Maganda yan. So this is a systematic review and meta-analysis were performed to determine the risk for failure to induce remission of lupus nephritis in patients who were treated with MMF. So these are 4 RCT studies. These are 4 RCT studies that included 268 patients who were identified. 133 were treated with MMF and 135 were given cyclophosphamide. So this is the forest plot of the relative risk. So the pooled RR for failure to induce remission for MMF compared with cyclophosphamide was 0.7, suggesting a significant treatment benefit for MMF based on this meta-analysis. Going further, this is the ALMS study. I know you know the ALMS study, the ASPRIVA, Lupus Management and Study Group. Recent studies have suggested that MMF may offer advantages over IVC for the treatment of lupus nephritis. But these therapies have not been compared in an international RCT. So here's ALMS trial wherein they report the comparison of MMF and IV cyclophosphamide as induction treatment for active lupus in a multinational 2-phase induction and maintenance study. But we will just be going through the induction phase. So they randomly assigned 370 patients with classes 3 up to class 5 lupus nephritis to open label MMF with a target dosage about as much as 3 grams per day or IVC. Okay, so the primary endpoint was a pre-specified decrease in urine protein creatinine ratio and stabilization or improvement in serum creatinine. Secondary endpoints included complete renal remission, systemic disease activity and damage, and safety. So the primary endpoint was a pre-specified decrease in urine protein CREA ratio. So this is the separation of 185, 185, so halos balanse sila. So this is the result. The overall result, they did not detect any significant difference response between the two groups. 56% with the MMF and 53% with the IV cyclophosphamide. Secondary endpoints were also similar between treatment groups. There were 9 deaths in MMF, there were 5 deaths in IVC. They did not detect significant differences between MMF and IVC groups with regard to rates of adverse events, serious adverse events, or infection. So it doesn't mean that if they have no difference, this is not good. But at least you have now an option. If you don't like or your patient doesn't like to use a cyclophosphamide, there is now an MMF that you may use, which probably you have a woman who is afraid to develop infertility, then you can have something to offer now. So just to show to you the overall, halos wala naman silang difference. Ano? So the rates of complete and partial remission in the ALMS trial after 6 months of therapy, induction therapy with either MMF or monthly IV cyclophosphamide showed virtually identical rates of remission. In subgroup analysis by race, non-white and non-Asian subjects showed significantly higher. Non-whites, so narito sila, and non-Asians showed significantly higher rates of remission with MMF than cyclophosphamide. So mas mataas sila dito, non-whites and non-Asians. Okay? So I think this is a beautiful paper. No? It was cited. No? It is only available online. This is 11 November 2014. He was generous. He answered the letter of Dr. Belinda. In less than 12 hours, she sent the whole text of the paper. It is only available online. So what is now multi-target therapy? No? I think siguro ito na yung trend going to this area. Multi-target therapy this is to assess the efficacy and safety of multi-target therapy consisting of tacrolimus, mycophenolate, and steroid compared with IV cyclophosphamide. So this is a 24-week trial from 26 renal centers in China. They used tacrolimus 4 milligrams per day and mycophenolate 1 gram per day versus IV cyclophosphamide with a starting dose of 0.075 per day. So their measurement will be the primary endpoint was complete remission at 24 weeks. Secondary, wala. Ayun, kala ko na wala na eh. Secondary endpoints induce overall response. So overall response is that you add the complete and the partial remission. So this study was limited because of shorter duration. Okay, but anyway, this seems to be promising. So they are randomly assigned whether to receive MMF and tacro versus IV cyclophosphamide. So after 24 weeks of therapy, more patients in the multi-target group, 45.9%, than in the intravenous cyclophosphamide group, 25.6%, showed complete remission. Okay? So the overall response incidence was higher in the multi-target group than in the intravenous cyclophosphamide group. So just to show to you further that the incidence of complete remission was higher in the multi-target group than the IV cyclophosphamide group among patients with class 4, showing we have 51.5 and 29.9 in class 4, and in class 5 we have 33 versus 7.8, and in combination of 3 and 5 we have 50 versus 39, and combination of 4 and 5 we have 45 and 26. So it seems to be promising. At the same time, the cumulative probability of overall response was higher for patients who received multi-target therapy, 85% versus 68% in the IV cyclophosphamide group. The median time to overall response was 8.9 weeks, meaning to say, if I start tacro and mycophenolate, I expect that in 8 weeks' time, I see results. Whereas in the IV cyclophosphamide group, I see results after 13 weeks. So faster ang effect ng iyong medication. So we know rituximab, you keep on using it for those who are in big centers, okay? This is good. This is good, okay? Rituximab, as you well know, is an antibody to your B cells, no? So you have to learn how to count your B cells, okay? So unfortunately, this paper has only 20 subjects. They use rituximab for induction for class 4 and class 5, and after 22 months, the complete remission or partial remission was obtained in 12 patients, which is about 60%. There is one relapse, no, but responded again with rituximab, and they have noted that RPGN did not cause response to the rituximab. So rituximab, dahil maliit ang papel nito, we can say this is interesting therapeutic option in relapsing and refractory lupus nephritis when early B cell depletion is obtained. That's why they are also counting the B cells. So another paper is, this describes the 6-month clinical outcome and the long-term therapy safety profile of B cell depletion therapy in 50 patients and the active SLE who were unresponsive or poorly responsive to conventional immunosuppression. So you can see here that after one cycle of B cell lowering agent, 19 of 45 patients achieved remission. And you will notice the BLAG. What is BLAG? BLAG is British Isle Lupus Activity Group. Oh, great. So it's a scoring system wherein, i-google nyo na lang. So they look at that. So there is improvement in BLAG, which is good. And there is also improvement in the C3, and there is also progressive reduction in the anti-dsDNA. So, this is now, I think, a very important paper. The Explorer trial tested the efficacy and safety of rituximab versus placebo in patients with moderately, take note, moderately to severe active extrarenal SLE. So, there are patients that are in background treatment already. They are already receiving azathioprine, MMF, and methotrexate. And each arm were randomized to placebo, rituximab, placebo, rituximab, placebo, rituximab. So what's the outcome? So at week 52, there is no difference noted in the major and the partial clinical responses between the placebo and the rituximab group. Okay, and the major, if you add the two, still there is no difference in the outcome of treatment. So, but you would see, that the BLAG index, at the end of the 52 weeks seems to be running parallel. So, maganda naman kahit paano sa BLAG, okay? And at the same time, yung time for the first moderate or severe flare, here, the flare, after the first disease remission was 4 months in both groups. So they are expecting relapse. So those on placebo, those on rituximab, pareho ang panahon ng kanilang pagkakaroon ng relapse, okay, ng flare. So the same thing, they did count the B cell, They would notice that there is much reduction of the B cell in the retox group. And the anti-dsDNA, there is just a slight lowering of the antibodies related to lupus among those patients who receive rituximab. So, same thing also, that there is a progressive increase of the complement among those patients who receives the rituximab. Okay, so in this Explorer trial, they have enrolled moderately to severe active lupus, and use aggressive background treatment and sensitive cutoff for non-response. Unfortunately, there are no differences noted between the placebo and rituximab in the primary and secondary endpoints. So it is not without hope for rituximab. It is just a matter of probably designing a better paper for us to see. Kasi maraming anecdotes, there are beautiful things rituximab can do. Rituximab is not a part of our standard of care, but you see it is widely used. So as a recap then, I would like to make mention that in lupus nephritis, the male is commonly suffering severe lupus nephritis, which probably we can attribute to, one, they have more susceptibility loci for lupus nephritis. And at the same time, the testosterone seem to be pro-inflammatory. They seem to activate the apoptotic pathway that can really induce programmed cell death in renal tubules. Though more SLE is seen in female, lupus nephritis is less severe in female, because it seems that the estrogen in itself seems to be protective in the renal tissues. So still the standard of care for proliferative lupus is cyclophosphamide. However, effort has been increasing to improve the remission with the use of multi-targeted therapy, which is promising, since right now we cannot say that MMF can really stand alone versus cyclophosphamide. But what I can say, that in as much that cyclophosphamide and MMF is halos magkapantay lang ang performance nila, you can bank on MMF instead of cyclophosphamide if you are afraid of having your patient develop. So, as I have said, MMF is equally effective as IV cyclophosphamide. So, hindi natin pwede isang tabi siya. Nariyan pa rin yan, nasa KDIGO pa rin yan. Pero ang isa talagang magandang nadi-develop ngayon na nakikita natin is the multi-target therapy. I think it is very promising. However, it is just done in China and it only consists of one race. And you would notice that if you go through the ALMS trial, there is also a sub-analysis of different race. Kagaya ng Lumina trial, they give emphasis on different race. Hindi lang nila ine-emphasize yung pagiging babae o lalaki. Kaya lang, talking about different ethnicity, malaking issue na naman pag-uusapan. So, I just did limit my issue here on being a male and trying to review what is in the future for the treatment of proliferative lupus nephritis. And also for rituximab, I think better design. Hindi pa naman siguro tapos ang lahat sa kanila kasi as you will know, this is an only off-label indication for lupus nephritis. So if you have any questions, I am willing to answer. Then you may have your merienda. Yes, Dr.
Addition of the use of hydroxychloroquine.
Yeah, I asked the rheumatologist, I deliberately deleted the tall R receptors. The tall R receptors are present in the surface of the innate immune cells, particularly the first liners. Sabi nga niya yung mga neutrophils, macrophages. Doon daw nag-work yon. They work in that tall R receptors, to hopefully prevent cytokine production coming from the innate cells. These are the ordinary first line defense, which they use basically, I think, more on the extrarenal nephritis. No? Hindi nila binanggit dito yung chloroquine actually sa mga paper na to. I have very, very little experience with that.
I'm not sure, sir, kasi parang I've read somewhere that there are benefits of the use of hydroxychloroquine in the progression of lupus nephritis, kidney-wise.
Okay. See, I think kasi ang isang mini-mention nila doon sa journal na hindi, again, deliberately deleted, it's the tall R. They are citing the tall R receptors. The tall R receptor, which is more common among which is an X-link. There seems to be those related with the X. So sabi nga nila, habang dumadami daw ang X genes, the more nag-work yung tall R receptors na yon. So I think the more we need the hydroxychloroquine. Any questions, our dear students? You try to read the paper from China. It's very good. I think kaya natin yun.
So in behalf of the Philippine Society of Nephrology, I would like to thank everyone for coming today and also for the Veterans Memorial Medical Center for holding the first Nephro Forum. So the next Nephro Forum will be on January to be hosted by the University of Santo Tomas. So we have prepared some meriendas for everyone and thank you for coming.